So in 2016, Geoffrey Hinton, one of the fathers of artificial intelligence and computer science, made a bold proclamation saying they should stop training radiologists now. As a medical student, this was very alarming to me at the time, but now I can say confidently 10 years later that radiologists are more important than ever. In this podcast called Radiology Rewired, we're going to go through all the facets of artificial intelligence and how it affects not only radiology, but the healthcare sphere as a whole. We'll talk to various business leaders, researchers, and startup founders and go through all the processes that AI affects and what we can look for in the future. So every episode, I'm going to highlight just a couple of news articles from high-impact publications. Today, we're focusing on the Washington Post. They had an article titled, AI hasn't killed radiology, but it is changing it. And in this, we're talking about 340 FDA-approved algorithms that exist right now in radiology. The goal of a lot of these algorithms is to improve the workflow of the radiologist and to reduce the number of cognitive tasks that we have to do when interpreting a study. What has happened is that these tools are very, very task specific, and they're not widely adopted yet. We also don't see that return on investment in a lot of the AI tools that are being developed. Hospitals are paying licensing fees, but not seeing that return in productivity just yet. So in the future, as we move forward and these AI tools continue to improve, the radiologist's role isn't going to be replaced. It's going to be redefined. Now the radiologist is charged with the task of verifying these outputs. That requires you to still know how the images are required, how the algorithm is working to extract the information, and for you to put it in clinical context with the patient's current environment, past treatment history. So you can think of it as an evolution of radiology. The radiologist used to be explicitly kind of focused on diagnosing and image interpretation, whereas now I think the role with AI tools obviously helping us and making us more efficient, is going to put more burden on the radiologist to make a compact impression that really integrates the clinical picture as well as the imaging findings with the output of the artificial intelligence system. The second article was from the New York Times titled, "Your AI Radiologist Will Not Be With You Soon." The idea here is that going back to what we were talking about with 2016 bold propositions about a radiologist being replaced. The fact is that has not happened by any means so far. There are few and far between tools that we use regularly that really impact care. Stroke triage and stroke care greatly impacted by artificial intelligence, not because of image interpretation. It's affected because the communication that it allows has improved so much. For example, when a patient previously used to come in with a stroke, they would have to get scanned in the CT scanner. They would have to get perfusion imaging. The neurointerventional team is waiting, doesn't know if the patient actually has a stroke or not, is relying on the radiologist to read all those images, then convey the findings to the neurointerventional team. Every second you waste not treating that patient, they have portions of their brain that are dying. Very big deal. Now you have AI algorithms that are actually notifying other physicians when a stroke is coming in, if it's positive, and they're able to review those images from their phone. That's a huge deal. But the idea that we can just let these AI algorithms go and just expect perfect results is completely false. The radiologist is still there to interpret the images, to verify the outputs, and then to convey those findings in the appropriate clinical context. Hi, everybody. So first episode, we got a great guest for you today. This is going to be Dr. Greg Albers. He is the co-founder and one of the heads at RapidAI. Long history in neuroradiology research, was one of the first people looking at diffusion imaging and stroke imaging and determining which patients are candidates for stroke therapy, and also changing the stroke treatment window, which is a huge deal. So Dr. Albers, so happy to have you here. Can't wait to hear more about your journey from, being a doctor and then starting an AI firm. What is that like?
Thanks for having me. Really a pleasure to be here. Well, it's very different being in the business world versus the academic world. So it's quite an experience that has been very enlightening.
Absolutely. So take me back through kind of how things got started. I think a lot of physicians are so locked in on clinical duties, and there are a few people that branch out into the business side. But I think that you branched out to not only business, but the AI side. And how did you get started so early on all this stuff?
Well, it really started back in the mid 90s. We had just started the stroke center at Stanford in 1992, and we're trying to find ways to treat stroke. At that time, there was nothing approved to treat stroke. And I had been taught in medical school that if you're going to treat it, it's got to be ultra early, that the brain is going to die so quickly when you cut off the blood flow. So we were looking at neuroprotective agents, and they weren't going so well. And it was really fortuitous that MR physicist named Mike Mosley came to Stanford right after making a very big discovery. He was looking in stroke models and looking at new MR sequences, and he figured out that diffusion MR could see a stroke right after it was created. So it's been very frustrating, as a resident to, go to the ER, see somebody with a major deficit, and then the CT scan shows you nothing. So you really have no idea, where the lesion is and how big it is, and is it irreversibly injured or not. So we started doing diffusion MR on all the patients at Stanford. This was at a time when MR was never done on stroke patients. And it was fascinating because what we found was that every stroke was different. And we actually got a grant to do 5 diffusion MRs on the stroke patients over the first 2 weeks. And what we could see is that there were some patients that were what we were expected based on medical school, that all the damage happened really fast and didn't get any bigger after a few hours. But that was the minority. Most patients, the stroke was growing slowly, often over 24 hours, sometimes even longer. We even had strokes growing for 3 days. So that was the moment where we said, look, if these strokes are evolving over this period of time, we should be able to treat them later, and we need to find a way to identify whose stroke is still growing and whose stroke has already come to completion. So that was sort of the idea that led to, we need to have a software that will automatically tell you how much tissue is dead and how big is the penumbra, how much tissue is at risk but still salvageable, because that would give an opportunity to individualize stroke care. So as long as the patient came in and had salvageable tissue, you could go ahead and treat them and throw away the stopwatch, because all the stroke research was done off a really tight stopwatch. Is it within 90 minutes or 3 hours? If not, forget it, too late.
And so what you guys discovered, though, is like in terms of how that impacted stroke care, what did that lead to in terms of stroke window and how that changed?
Yeah, so the first part was, establishing that the diffusion image really identified tissue that was dead, and that as the diffusion grew, it meant the stroke was growing. But the other component of that was, how do you know how much tissue is at risk? That's when we started doing perfusion imaging. So we would give a bolus contrast. We were doing all this with MR at the time, and we could see how much of the brain had abnormal blood flow. And what we would find is that if the patient didn't have the clot removed, the diffusion typically would grow into that perfusion lesion. So the idea was that if you had a mismatch, a small diffusion lesion and a large perfusion lesion, that identified somebody who could still benefit from therapy. So we started off trying to convince the NIH to sponsor a study that would allow us to help prove this. And that took 3 NIH submissions because there was tremendous skepticism. Everybody was really ingrained in this idea that, time is brain, and it's a very, very short time that you have. So that the idea that we had was, all right, let's try to use a clot dissolving agent at double the approved time. So by this time, 1996 had come along, and our first treatment for stroke was approved, TPA, clot buster, but it was approved with a 3-hour window, and the realization that most of the benefit in that trial was patients treated within 90 minutes. So our proposal was, I want to take patients up to 6 hours, and if they have a favorable profile on this imaging, give them TPA. So people thought, oh, that's a crazy idea, you're going to hurt people. But after 3 grant submissions that finally got approved, it's called the diffuse-1 study, and we showed that if these patients had the favorable imaging and they got the TPA and it opened the vessel, they were walking out of the hospital. They had a tremendous clinical response. So that's when the idea for the company really came about. Because at that time, to get these images, it was taking about 150 mouse clicks and about a half an hour. So this was never going to fly in the real world. So we said, we need to have this automated. And then had to look around to see where we could find some money to bring in a software engineer who could make an automatic map of the diffusion and the perfusion lesion.
And that's kind of how you guys were able to get the ground truth data, right? Based on the diffusion images, those usually corresponded with what was the dead brain portion, right?
Yeah. What we would find is that in patients who had complete recanalization, if the TPA opened the vessel and the blood flow was restored, that the final stroke volume would match the diffusion volume. If the blood vessel didn't open, that diffusion volume would continue to grow and it would match the perfusion volume. So we were able to basically predict what the infarct volume would be based on this early imaging. So here's our early imaging. Then you say, if the patient reperfuses, the stroke volume will be X. If the patient doesn't reperfuse, the stroke volume will be Y. And the trials that we did at that time confirmed that this seemed to work. So the next step was to be able to prove that somebody with this favorable imaging at a late time window could have a benefit from different stroke therapies. So we started with the clot dissolving medicine TPA, but soon evolved to physical clot removal with catheters, what's called thrombectomy, right? We reach in, pull out the clot, and restore the blood flow. So the next study that we did was a 12-hour window. So we doubled from 6 to 12. And that was also difficult to get through the NIH. The reviewers said, oh, you'll be looking for a needle in a haystack. Nobody's going to have salvageable tissue at 12 hours. And the grant was rejected. We put it in again with more preliminary data, and it didn't quite make it, but it was close. And that was right around the time that President Obama was elected. And it's actually Obama who got us over the hump, because what he said is that we're going to put out this American Recovery and Restoration Act, which funds grants that will employ a lot of people, even though the grant didn't quite make it. So we got the Diffuse grant through that program, through the federal government's assistance. And the other caveat that they had was you had to finish it in 2 years, which this was a 4-year plan for this study. So we had to rush. And by this point, we had the automated software that was, showing the images. So if the patient had the favorable imaging, they got into the study. And then what we could see is that if the clot was successfully pulled out, the patients did much, much better, even at 12 hours. So this was really exciting. But to have an impact on guidelines, we had to do a big multi-center randomized trial where, half the patients would be treated and half the patients wouldn't. So that was our next step, which again was the third Diffuse trial. It was called Diffuse 3. And we had a 16-hour time window. So we kept pushing it further and further. We wanted to go to 24, but the grant reviewers said that's insanity. Like, no way can you do 24. But at the same time, one of the device companies said, well, we'll do 24. So we had 2 trials running simultaneously, one sponsored by the NIH, Diffuse 3 at 16, one sponsored by industry with a 24-hour window. Both of them were randomizing patients. So these are patients who would come in who had never been treated before. So standard care is just medical management. But half of the patients in both of these studies had the clot physically removed with a clot removal device. Both of the studies got stopped early for overwhelming efficacy. There was huge, huge efficacy in these trials. So by December of 2017, we had the results of both. And in January of 18, there was a big American Heart Association stroke meeting in Los Angeles. We were able to reveal the results and simultaneously get new guidelines published, because we had been able to give the data to the American Heart Association early, so that on the same day that we published in the New England Journal and revealed the results in Los Angeles, new guidelines came out that said now the stroke window is being expanded all the way out to 24 hours. But to treat somebody, you needed to do the advanced imaging, because many patients, of course, by 24 hours, horse is out of the barn, all the brain at risk is dead. And we know that returning blood flow to a large chunk of dead brain doesn't do anybody any favors. It can cause swelling, it can cause hemorrhage. So this really gave a huge opportunity then for the company to take off.
Absolutely. So that makes sense. So, but I mean, even with those innovations, it was happening over what, 20 years of just fighting for grants. But then the end result is you have new guidelines and so many more patients are getting treated and so many more patients are having better outcome from this. So it must feel great to get to that point, right? After all of that fighting with and pushing grants through.
Yeah, it was amazing. Along the way, we had to deal with the FDA because before we could get this out into big clinical trials where the software was going, worldwide, uh, we had to, get an approval through the FDA, which is something that most academics have no experience with at all. And so the software was owned by Stanford University because we developed it at Stanford. So we had to go to the Office of Technology and Licensing to say, hey, this is a product and it needs to go through the FDA to become a real product. So it has to have a company. So that's when we needed to find somebody to help support this idea. And we were very lucky that a guy named Don Valentine, who was some people called the godfather of Silicon Valley VC, was interested in what we were doing. He's the guy who started Sequoia Capital. And he was interested in the research and actually was the one who put up a donation to Stanford to allow us to hire the software engineer to develop the software. A guy named Matt Straka was hired. Don was a tough guy, though. He said, look, this is a little far-fetched. I'm going to give you enough to have a year with your software engineer, come back to me in a year and show me that you've got something that works. And, the software engineer said, this is a 2-year job. So again, time pressure. So we beat on him. And in a year, we came back to Don and he was impressed that it was, identifying diffusion and perfusion imagings, coming up with the volume. It was done on something that looked like a little Mac Mini. Took about 10 minutes to crank through, but he got the pictures. So he said, okay, I'm going to give you money to continue so we can bring this forward. But let me tell you something. You're never going to get this through the FDA. Because you said Sequoia Capital, we used to do medical, but the FDA is so challenging that, we've gone to tech now. So we said, well, let's give it a shot and see if we can get it through the FDA. One of the big hurdles was that this is fully automated, and there was nothing before that was fully automated. So you're trusting the software to give you the correct answer with no human interaction. So that's part of the reason that Don didn't think it was going to fly. And it took us 2 years of work to get it through the FDA. I took sabbatical from Stanford. We were working hard to meet the FDA criteria, and lo and behold, they approved it. I think it was actually during a government shutdown where we thought it actually got approved. So then he was shocked and he said, well, now you have to have a company. So he offered some space and he said, we'll put some money in here so you can hire a CEO. And, you guys are academics. You don't know how to run a company. We got to get somebody in here who knows what they're doing. And we started the company in about 2016. Just as these trials were going. And then, in 2018, where this became a really important software for treating patients, then that was the time that the company was actually able to expand from just a handful of people to a large group that's now grown to over 250 employees.
Yeah, that's so impressive. And it's really interesting to hear that the initial research was all based in academics and then was kind of transferred over to private practice. And you were kind of like the liaison making that happen, which is really cool because you've seen it from both sides now.
Yeah, well, the company was very fortunate because usually you start a company with an idea and you have to do all the research. Here at the time the company was formed, we were basically there. We had been able to establish through NIH-sponsored trials that this looked really, really promising. And that was also around the time that AI was taking off, right? That suddenly that AI was the hot topic and it gave the opportunity to say, all right, we've done this product that helps you expand the time window for treating stroke, but there's a whole lot of other things related to stroke that AI could help. Identifying a brain hemorrhage, measuring how big it is, checking if it's growing or not growing, identifying a large vessel occlusion, all sorts of different things. And there were, a hot topic. Can we expedite how quickly a stroke patient can be treated by combining the AI imaging with a communication app, which will allow doctors to quickly move a patient into the right place to get the treatment. Because life on call for many years had been, you get a call from an outside hospital, they would describe some imaging, which, you couldn't see. They describe a patient, they think they're having a stroke, you transfer them over, and they had Parkinson's disease, or they had a brain tumor, or they were drunk, right? All sorts of different things, which made these transfers highly inefficient and also involve many, many phone calls, because you think the patient has come over for one of these thrombectomy procedures. You've got the team waiting, they're ready to go. You fly them over, and then it turns out to be a false alarm. It's a huge financial waste. So one of the big efforts that started shortly after 2018 was, let's develop an app where you can share imaging, where, you don't have to worry about HIPAA because it's HIPAA compliant. You can see the imaging in the outside hospitals, and you can also pull in your interventionalist. So the neurologist could say, hey, this looks good. Interventionalist you could look at the screen at the same time. And by doing that, you could have a much faster interaction with the ER, because that's what the ER wants. They want a quick yes or no. So you could give better advice to the ER. You could say yes or no. And what we found was that the rate of futile transfers, futile meaning that we flew somebody over, ambulanced them in, and we didn't have anything to offer that couldn't have been done at the originating hospital. That rate went down to practically zero. So huge economic benefits for cutting out these futile transfers, and also speed. You could get the patient to the right place much, much faster. And obviously, time is brain, that we know everybody has a different time clock, but for every patient, you want to treat them earlier. Earlier is always better. So by using the AI-based app to get the patient in quicker and to communicate with your colleagues, you could get the clot out a lot faster.
Absolutely. And I've definitely seen that in practice. And for, all our listeners out there, this app that, that they established is called RapidAI, one of the, several AI tools out there, and one of the specifically neuroradiology ones, but something that I've used and I've seen at several institutions. It has become a huge thing all over the country and outside of the country. There's people in other countries using this, but it is able to essentially comb through those images when we first get those perfusion images about blood flow in the brain, is able to find and target those areas that are getting really low blood flow, and then map out those areas that are likely already dead, which corresponds to that diffusion imaging. And the biggest part of it for us, and this is what he's talking about in terms of that treatment time. Our interventionalists get it on their phones. They can scroll through the images. They're not sitting at home or anything like that. They know exactly when their pager is going off, what it is, where the occlusion is, and they're able to formulate kind of a treatment plan before the patient even gets there. And that obviously leads to much better outcomes. So it's a huge, huge deal in stroke care.
Yeah, and the app continues to evolve. The newest version is essentially having a PACS in your pocket, right? That you can look at the axial, the coronal, the sagittal images. You can localize lesions in three-dimensional space. If the patient is in the scanner tilted, it can be hard to read the image, so you can untilt them just right in the palm of your hand. And seeing the source images, it's incredible. But there's also new ways now to do quick analyses so that you can see beautiful three-dimensional views of the blood vessels all the way from the aortic arch into the vertex of the brain. And then using your fingers on the app, you can twist the head into any angle. So, the blood vessel's taking a funny course, you can see exactly where the occlusion is, which is very helpful for the person who's going to do the procedure to say, hey, that's not one I can get to, or this is a great case, bring them over.
Yeah, and I've seen that firsthand, so working with some of the neurointerventionalists where they're trying to teach their fellows and they have those images pulled up. Just off of that, they're like, what route are you going to take? What catheter are you going to use? What bend do you have to worry about? And how do you maneuver the catheter to get around there to get to the clot? So these things are already discussed before the patient even gets there, which you can imagine just really expedites care and leads to better outcomes too, which is huge.
Absolutely. They're particularly helpful for people with anomalies of the aortic arch, because you need to know what's the path. How am I going to get to this clot? And, there's an anomaly that's fortunately not too common. It's an unflattering name. It's called bovine arch. Basically, your aorta looks like a cow. But normally to get into the left carotid, you just come up the aorta and you go right in. But in these patients, the left carotid does not come off the aorta. It's coming off brachiocephalic. So to get in, it's way easier for those patients to go in from the arm, to go in from the right radial straight into the vessel. So you, again, save a huge amount of time knowing in advance that you've got this anomaly and you're going to be able to get into the clot way faster if you go through the arm rather than the leg. So again, being able to plan these procedures basically as they're driving in to do an emergency procedure, it's a huge advantage.
In radiology, every second counts, and every image tells a story. RapidAI is redefining how those stories are read. From stroke to aneurysm and beyond, RapidAI's clinically validated imaging platforms turn complex data into clear, actionable insights in seconds, not hours. Trusted by leading health systems and backed by over 700 peer-reviewed studies, including 11 in the New England Journal of Medicine, RapidAI helps radiologists see more, decide faster, and deliver care with confidence. Because the future of radiology isn't man or machine, it's both. RapidAI, redefining what's possible in radiology. And you were talked a little bit about how when the company was first getting started, it was just this huge explosion of AI. And that's kind of when I was in medical school, and it was just a lot of hype around it and people saying, it's going to, blow up and take over radiology. A lot of people were like, very confident about that. How have the perceptions changed over the past, 10-ish years since it became really big? And what do you expect moving forward?
So there are tons of misperceptions. And I went to radiology meetings about that time as well, where people would get up on stage and say that, don't tell your kid to go into radiology. The job is going to be taken over by AI. And we knew at that time, as we know now, that couldn't be further from the truth, that particularly then, when AI was new, there was a lot of false positives and a lot of false negatives. The sensitivity and specificity was not nearly as high as it is now. But even now, AI is not perfect. So that's a misconception that people think, oh, AI, it's always going to get the right answer. And AI is very complicated to put it together right. You can imagine that protocols are changing rapidly. There's multiple different types of scanners. So when you train your AI, you have to train it for protocols that don't even exist at the time you're training. And when new protocols come out, your AI might not work. It was trained for something different. So you have to train for, all the different manufacturers because they handle images differently. So there's a lot to think about. And what's really evident is that even the best AI can be fooled by artifacts that, as a radiologist, you can read a scan and just instantly say, well, that's an artifact, right? Don't worry about it. But the AI may not be able to do that. So it may come up with a positive finding there. And it's absolutely essential that the human look at it and say, no, that's an artifact, or this is a false positive, this is a false negative. You don't want to take the AI at face value. The FDA is very clear about that. So that's a misconception. And then when people have that misconception, they get very angry at the AI because they see that there's a mistake and they say, oh my God, this is worthless. And it's, again, that's a huge misconception because humans make mistakes too. And what we've seen over and over in the studies that we do is that if you look at the accuracy of the AI and the human together, it always beats not only the human, but the AI. So it's putting the two together where you're going to get optimal results.
Yeah, and I think that really highlights one of the quotes that we talked about in this episode about, these two articles we're talking about how your AI radiologist will see you now, and how AI is affecting radiologists right now and what was predicted before. But I think one of the most famous quotes that's said over and over is that the radiologist with AI is going to, beat or just outlast the radiologist who refuses to use AI. And that's probably true for clinicians in general, right? Like it's becoming so pervasive now.
Well, our goal is to make the radiologist's life more efficient. There is an explosion of imaging. There is so much imaging going on, and there are so many demands on the radiologist to read this huge volume of scans in a short period of time. Obviously, mistakes will be made. People are stressed trying to get all those scans read. So what we've been working on is finding ways So you can read the scans faster with better accuracy. We have a new product that was just FDA approved a month ago, and it allows you to co-register the last CT scan to the current CT scan. And it is incredibly helpful, particularly for patients with neuro ICU, brain hemorrhages, hydrocephalus, type of things that are in the ICU where they're getting repeated scans and hemorrhages are growing and ventricles are blowing up and you've got obstructive hydrocephalus. What it does is it has a color code to show you exactly what's changing. If a ventricle is getting bigger, you see the area that's bigger in dark blue. If the ventricle is getting smaller, you see that area that shrunk in light blue. Hemorrhage getting bigger, that's flagged in a color. And after reading about 15 scans and getting used to this color presentation, we've seen that this cuts 30% of the reading time for reading these type of scans with better accuracy. So not only do the radiologists read faster, but they can read more accurately. The other thing that can help radiologists is to be able to flag the most important scans to come up to the top of the reading list, because you may sit down with and you got 30, 40 scans to read, and you come down and see that there's one who's in the ER with, brain hemorrhage, midline shift, obstructive hydrocephalus, obviously needs to go to the OR, and you want that read to be flashing at the top of your list. So by the AI being able to say, hey, this looks really serious, let's put it to the top of the list. That, again, a big advantage. A lot of what we did in the early years was really focused for clinicians who are treating patients, because in the middle of the night, we often didn't have a radiologist available, right? So how can we help figure out who's the right patient to treat in the middle of the night? What we've been doing more recently is saying, hey, we need to look at what's helping the radiologist. So, what can we do that the radiologist has a hard time doing on their own? Calculating the volume of a brain hemorrhage is not easy. There's a trick radiologists use called ABC/2. It's a shortcut. They can do it quickly. It's not that accurate, particularly for unusually shaped hemorrhages. So to have an automated hemorrhage volume that can come out instantly, less than a minute, you got the volume, and then it can allow you to track, because after somebody comes in with a brain hemorrhage, typically you're going to do a 6-hour stability scan. And what we would often hear from the radiologist is, well, it looks stable, but the technique's not the same. They're tilted, not quite sure, do another one. And here you say, well, the volume was 15 6 hours ago. It's still 15. Clearly, it has not changed, which can also help you avoid transfers. A lot of hospitals, community hospitals, they see a brain hemorrhage and they say, oh, I can't handle this, send the patient over. But many of these are small, stable hemorrhages where nothing is going to be done. The patient is just going to be monitored, you can watch their blood pressure. So you can save a fortune by not transferring these hemorrhages. So by having the volumes available, that's really helpful. For an aneurysm, having a volume of the aneurysm and the surface area can be incredibly helpful as you trying to say, here's my scan from 6 months ago, here's the new scan, co-registering it, get the neck plane lined up. Now you can say much more definitively, this aneurysm is stable. Because what we found is that there's, fortunately not common, but there are cases where standard imaging, radiologist says the aneurysm is stable, don't worry, come back in a year, and a few months later, the patient has a subarachnoid hemorrhage. And we found that when you look at those cases, that if you had the analysis by AI, that virtually every time the AI would have told you that was not a stable aneurysm. That's an aneurysm that's had a shape change or a volume change or a surface area change, and shouldn't be coming back in a year. It should be getting treated.
Yeah, I think that's a great point. And one of the things that really contributes to radiology burnout is just measuring stuff and being like, is this stable or not? And like you said, there's different factors, like, it's increased in this dimension, but has been stable in these dimensions and things like that. And for things like aneurysms, I mean, a lot of times these are 2 millimeter things. And for those who don't know, when they show up, it's just like this little dot, this little outpouching. And for us, we can zoom in as much as you want. There's only so many pixels. Sometimes it looks a little bit bigger, but overall, if it measures the same, we're usually going to call it stable. But there are so many micro factors that maybe we don't know about or that come out because of AI tools that we begin to realize how these type of things can change. And then now we have a whole new way of monitoring, certain types of disease processes that actually impacts clinical care.
Absolutely.
So I wanted to touch base more about the FDA process because I think you're one of the most unique people to speak on this because you've seen it from all fronts, and not many people have gone through that process of taking something from the research stage to becoming a big product that's used nationally and internationally. So can you talk to me about what that takes to get your technology through the FDA and what kind of barriers you guys dealt with?
So it's really important to communicate with the FDA. They're very happy to talk to you and give advice. They won't tell you what to do, but you make a proposal and they'll tell you what they don't like about it, which is usually many things that they don't like. And it gives you an opportunity to see how they're thinking and what they're looking for. So, what they're looking for is a product where we can be confident that this is going to perform in the real world the way that it performed when you did your development. So very important that the development data is going to be completely independent from the data that you use to validate, right? Because that would be a conflict, right? That you want to be able to go to many different sources to get the data. So you need data from all the different manufacturers. You want data with various protocols. And you can define the parameters. You can say, my product will work for such and such slice thickness, or other parameters. And then if you have specific parameters, it means those need to be, considered when the program is used clinically, because we've certainly seen that people try some protocol that is incompatible with the software, and then they're frustrated that the results don't match up. But what you need to do is have access to a lot of data. And it used to be easier to get data, but now people have realized how valuable data are, so they want to charge a lot for it. So you have to find a good data source. The FDA wants to have a consecutive series in your data, because if you just cherry pick cases that are really good for your software, obviously results are going to look better. So consecutive series, multiple manufacturers, and then you need good annotators, right? Because you're going to be annotating the disease of interest so that the computer can learn that this is what an aneurysm looks like, or this is what an LVO looks like. So you have to be very specific about the definitions. What LVOs we're considering. The LVO software that initially came out was just picking out distal ICAs and M1 segments of the MCA. Wasn't picking out all LVOs. So that was a little bit of a misnomer, and people would get frustrated and say, why didn't you pick up the Basler? Wasn't trained on the Basler. So you've got to get a lot of what you want to detect. You have to annotate it clearly, and then you have to take a look at the results and figure out what's causing your false positives, what's causing your false negatives. And then once you figure that out, you can retrain and retrain. And sometimes you don't figure it out until it's out in the world. That when our first ICH detection software came out, it had a good specificity, but it wasn't perfect. And ICHs aren't all that common. So even if your specificity is 95%, that means for every 100 scans that don't have an ICH, which is most scans, you're going to have 5 false positives. And people don't like false positives because they might get woken up by a buzz at night saying there's a brain hemorrhage, and you look and you don't find it. And then you get frustrated because, am I not seeing it, or is it not there? And once you realize it's not there and it was a false positive for the software, that can be very frustrating. So by figuring out what was causing them, we could retrain and get the specificity way up. But for aneurysm products, for example, you really have to understand what the specificity means and what's the incidence of the disease to figure out how to use it. So what's on the market right now for aneurysm detection, triage and notification, meaning I'm not going to show you where it is. I'm just going to say, I think there's an aneurysm here. Those have a specificity that is in the low 90s, right? And aneurysms are only about 3%. So if you're trying to screen a huge population and you'll capture the 3% that are true, but for every 100, you may get 7 false positives. You have to understand that this is going to find aneurysms that I missed, and you could screen the last 1,000 cases that were read in your department, and you would find aneurysms that were missed. We've seen that multiple times, which can be really helpful, right? For malpractice, other reasons.
Also scary.
Yeah, also scary. But you just understand that this software is going to give me several false positives for every winner. And if you understand that and you're running through and you say, okay, these were false positives, but here's a good one, then you realize that the software is valuable. But what we've tried to do is move from triage and notification, which is I'm AI and I suspect a disease, you find it, to a higher level of clearance through the FDA, which is I found a disease, here it is. So the first one we got through the FDA with this higher level of clearance, which is you can say not suspected, but I've detected something, was the aspect score, right? Where we're saying here are the aspects regions that are positive, we're identifying it. And now for aneurysm, we have a software that will find the aneurysm, say, hey, it's right here, I'm coloring it red, and do measurements that radiologists can't do. So again, really value for radiologists is when you can give them something they can't do on their own. That's why the diffusion-perfusion and subsequently CT perfusion was so valuable, because you can't give somebody raw perfusion images and say, hey, how much tissue is salvageable? But the AI can give you it and say, it's right here, it's 40 mLs. This is the tissue, this is the part of the brain that's affected. So that's the type of AI that is really helpful for radiologists, that not only can it make their read more efficient, but it can show them something that they can't find on their own. And then if you can generate the report for them so that they can just tune it up, then they're very happy. So a lot of the attention now is sort of swinging back to how can we make things better for radiology, where the early days of the AI apps were, how can we make it better for the doctor who's on call tonight and doesn't have a radiologist?
Sure. Yeah. And I think you hit the nail on the head in terms of what I think is the big, confounding factor in a lot of these new AI tools is, does it move the needle for are we going to be more productive? Are we going to have better outcomes? Because, finding things here and there, it's helpful, I guess, but at some points you're just looking at more outputs and it's just more data to look over as the radiologist, more images to scroll through. But if you do have something that's improving communication, improving outcomes, like you said, doing things that we don't want to do or can't do, I think that's really where the value lies.
Yeah, your point is really well taken, that if you've got 20 AI modules going and it blasts you with 20 results, you're overwhelmed because most of those 20 are not going to help you at all. So we have a breakthrough designation now through the FDA, which we're very excited about. It allows the modules to work together so that we don't give you things that you don't need. So one that's on the market now, it's called NCCT Stroke. What it does is it takes a look at the non-con CT and it says, is there a hemorrhage here? If the answer is yes, then it goes down the hemorrhage pathway to say, what do you want to know about a hemorrhage, right? Is there midline shift? What's the size? Is it a subdural? What type of hemorrhage it is? Is there hydrocephalus? If there's not a hemorrhage, you don't need those things. You want to know, well, is there a hyperdense MCA sign? Is there an occluded vessel? And where is the occluded vessel? So we now can put a heat map on and say this is a distal MCA branch, or this is the basilar artery. So really to show, okay, here is the vessel, and then how much hypodensity is there? What we've seen from the recent large core trials is that for a given aspect score, you could get that score because you have very mild hypodensity, or you could get the exact same score with very severe hypodensity. And the prognosis is totally different, and the response to thrombectomy can be totally different. So being able to focus in on what's really going to make a difference on who should be treated and who shouldn't, that's what the AI should do, rather than blasting you with 10 results.
Yeah. And I think that some people are really concerned about just alert fatigue in radiology. Like you mentioned, you might have 20 outputs alerting 20 things. It's just like when you're in the, in the ICU, every machine has an alarm that goes off and their thresholds are so high or so low that there's just constant alarms blaring in the ICU, and you get alarm fatigue. But something actually does happen and the alarm is going off, some people just don't hear it because there's so much other stuff distracting them. And I think that's a big concern for some people in radiology, where you're just like, I'm already looking at so many images, I don't need all this other stuff, just adding more to the workload.
Yeah, so that's a big challenge for AI, to be able to tailor the outputs to things that are really going to help and not fill up the packs with a ton of images. Because if they're there, then the radiologist has to look at them, and then the AI can make it longer for them to read a case. The goal should be, we want it to make it faster for the radiologist to read the case.
Absolutely. How do you see liability issues with AI and AI outputs evolving over the next, 10, 15 years that becomes more pervasive?
Yeah. Yeah, great question. You know, certainly there is some AI that can decrease liability. One of the reasons that community hospitals were excited to adopt the CT perfusion software is because it makes it much easier to tell who's a stroke mimic versus a real stroke, or what we call a stroke chameleon, which is when the patient comes in and they seem to have another disease, but it's actually a stroke. Because when you think that it's something else and the time window for treating the stroke disappears, there's a lot of risk. Right now, one of the biggest malpractice risks is basilar thrombosis. And it was a case in New York a couple of years ago, a $110 million lawsuit for missing a basilar thrombosis, because we now have clear data that doing thrombectomy for those patients makes a big difference. And many of these are patients who will, have a history of substance abuse. They're younger, so people come in and, the patient is unresponsive. They just assume it's an overdose. And then they miss the fact that there's a clot that should be pulled out and could have a huge impact. So having the AI show you, look, there's a perfusion deficit, or identifying, hey, there's a basilar thrombosis. I mean, that's huge, right? So, and even, a standard middle cerebral artery occlusion, sometimes it can have an unusual presentation. And if you miss that, it's beyond the standard of care, right? That the patient missed thrombolysis, they missed thrombectomy. So that can help reduce liability. And we just talked about aneurysms, that we're blasting neuroradiologists with CTAs because everybody's doing CTAs now. And many of them are being done because the patient's had a stroke and they find the vessel occlusion and great, I found the vessel occlusion. But there was a PCOM aneurysm that was missed. So again, that's how AI, it can be used in a totally different setting. Rather than in the heat of the battle, you can then screen your past cases and pick up things that may have been missed that aren't ultra acute, like a 3 millimeter aneurysm, right? It's not going to be treated right now, but it's good to know because you want to follow it. So, the whole goal is to make liability go down by helping not to miss things.
Yeah, I mean, and for those listening, we have this concept in radiology called satisfaction of search, where, you open a scan and you think something's going on and, you're supposed to go through your normal search pattern, which, you do. But if what you think is going on and what lines up with the clinical story and you find that thing, like he's saying, like, oh, this person has a right MCA stroke, boom, answer solved, scan done. But you're just not combing for another answer. And then that's how things get missed. So things like this that have like almost like a second set of eyes running in the background, flagging things for you that you might have missed. I mean, I think that's what I think will move the needle a lot. Cause like you're saying, it's going to pay dividends in liability. And I think everybody is concerned about missing small things in all private practices and academics and stuff like that. So I think that translates really well to getting adopted as well.
Absolutely.
So I was also going to ask, like you start in one kind of area, right? I know Rapid, for example, is started as, stroke imaging. We talked about the kind of the origins. And then now you guys are expanding into different parts of the body, looking for pulmonary embolisms, aortic dissections, things like that. So multiple fields getting involved. How does that process work, or how do you go about expanding?
Right. So we were totally focused on the brain and saying, what else can we do to help neurosurgeons and interventionalists and neurologists? And then somebody suggested, well, pulmonary embolism is just like a stroke, right? You've got a blood clot that's blocking off a blood vessel, and people are starting to be more aggressive with treating pulmonary emboli. In addition to thrombolytics, they're going in and doing thrombectomies. But they were not very well organized. It was kind of like the early days of stroke, where patients would come in, the door to needle time was really long, early days of thrombectomy, really long time from door to femoral puncture. So we said, why can't we do the same thing for pulmonary embolism and help develop, PE codes and PE teams that are going to be able to treat more patients and treat them faster. So first thing was, let's detect the PE. So we have, detect the PE. And then for pulmonary, you want to know, is there right heart strain, right? So it was not too difficult to design a module that's going to do RV-LV, ratios and figure out whether you've got right heart strain. And then you put it together in the app so that they can communicate and they can get the lab ready to accept these patients. So it was sort of a natural transition. Some companies have gone the way of saying, okay, I'm going to do basic triage and notification for everything in the body, right? So then, use us and we got the whole body covered. The problem with that is the whole body is very complicated. And, you want to go beyond triage and notification. You want to have, identification, measurement, some of these novel things that we've talked about. So one of the things that we've done is develop a system where you can bring in apps into the system. So if you have an app that you like for breast, you can bring it in and it runs through the Rapid system. So that way you're not saying, okay, I'm going to choose this group because they cover most of the body. You can say, I'm going to choose a group that does a really good job in the brain and also is able to bring in other modules that are of your choice and run through our cloud, run through our platform.
Wow, that's a great concept. I did not know that existed. I hope that's ongoing at my institution because that would be really clutch. I think adding on, like having all those profiles running in one seamless system is probably like the most ideal thing.
Yeah, it drives radiology departments and administration crazy to say, I've got to have 10 different AI vendors, right? So that's why some have gone this route of, okay, we'll take a vendor that has the most diseases, but that's really not what you want because that's not going to give you the best stroke app or the best hemorrhage app or the best aneurysm app. So, being able to open up the platform to bring in new modules. And because of that, we've been able to bring in, cervical spine fracture and be able to bring in some cardiac modules. So being able to expand, but also open up to, if your favorite module is X, it can run through this platform and that way you don't have to deal with 10 different AI vendors.
Yeah, and you don't have to abandon them either when you kind of move on and there's like some kind of conflict or something like that.
Say this was the best app for kidney. I want to keep this even though I'm shifting over.
Every image starts as data, but in the right hands, it becomes a life-changing decision. RapidAI gives radiologists the power to move from scan to strategy in seconds. With deep clinical AI built on 700 plus peer-reviewed studies and seamless integration into existing workflows, RapidAI helps teams catch what matters most, faster. From stroke to pulmonary embolism, from rural hospital to major medical center, RapidAI connects people, insights, and outcomes. Learn more at rapidai.com. And one of the other things I was going to say was, like, as far as measurements and things go, that's one of the biggest kind of burdens on a radiologist is just measuring things. So like you said, I mean, I think from our perspective, if it just says there's an aneurysm and I still have to go look for it, measure it, compare it to the prior, that doesn't save me a ton of time. But getting that raw information of localization and actual assessment, I think is huge to provide value, right?
Yeah, and putting it right into the report because it takes a long time to dictate these reports. There's so much complex, neuro info that's coming out. And so we're really trying to find things that are going to make the radiologist's life easier. Another thing I was going to mention that is very underutilized is the fact that CMS is providing some reimbursement to the hospitals for taking on AI. A few years ago, there was what they call an NTAP for LVO software, which provided very nice reimbursement to the hospital. There's one now that will reimburse for the automatic brain hemorrhage measurement. There's an NTAP for obstructive hydrocephalus detection. So grossly underutilized. Hospitals that are utilizing these are paying for their AI. They're having, very, very nice reimbursement. So it's something that people need to realize is out there that, CMS has made available to help hospitals adopt AI.
Is that something that they have to basically apply for once they get the software? How does that work?
No, you don't have to apply for it. The codes are out there. You just have to document that the software was used. So there's some language that goes in the report, and then they submit the bill and they get reimbursed for using software. So it's not all modules. There's just certain modules, and sometimes it's just 3 years of an approval for an MTAP. Some of them are long-term approvals. So really something that I think hospital administrations have been a little shy. They think, oh, maybe this isn't legitimate, but many hospitals are now taking advantage of this.
Yeah, I mean, I think they're going to have to, given the fact that, I mean, I know in residency and fellowship, I kind of saw the beginnings of integration and seeing it in the workflow. And one of the reasons that we didn't, let's say, for like a pulmonary nodule detector, or for compression fractures and automatic measurements and things like that, one of the reasons we didn't retain those licenses was because they just weren't getting enough value out of it. They're paying a subscription fee, all that kind of stuff. But I think like ameliorating that cost with the reimbursements from CMS is going to be huge in the future for adding on new AIs.
Yeah, return on investment is critical. Anytime you take on an AI module, you have to say, what's the return on this investment? Right? You can't buy all these modules. So you have to pick and choose what's going to make most sense for your practice and the bottom line for your institution.
Yeah, I think and ROI is judged very, I think, differently by different people, right? Different, for us in radiology, we might look at it like, oh, my job just got better because I'm, catching more, patients are getting treated better and stuff like that. A private practice owner might look at the bottom line. Are we increasing efficiency or not? The hospital is looking at hospital metrics. What's the door to thrombectomy time? What's our turnaround time? What's our readmission rate? So I think depending on who you ask, there's different factors that are going to have various, levels of importance.
Yeah, and it's very different in different systems. I was just at a meeting in Australia, and they told me that the person who pays for the transport, not the person, the institution who pays for the transport is the sending institution. So you're a community hospital and you're going to send for a thrombectomy, you cover the cost of that transport. So if you have an AI tool that avoids unnecessary transfers, right, it's huge because you don't have to cover that cost. And that is one of the biggest financial benefits of AI, is these unnecessary transfers that are so expensive and so disappointing when somebody comes in and there's the expectation they're going to get a procedure and then they don't, and they need to go back to their institution. There's a lot of different areas where AI can help. So you have to kind of sort out where is that ROI for your institution.
And I think it's twofold, because not only is the institution that got the patient, they're paying for the transfer, but also they're losing on all that income from treating the patient or just keeping them in-house. And even those hospital day stays, all that income is gone.
Yeah, absolutely. So in the US, that's very relevant. I mean, when we went out this years ago to our referring hospitals and said, hey, you should start doing CT perfusion. It was like, what are you talking about? We've never needed this. Why is this going to be helpful? Eventually, we talked to all our main referring hospitals, so our 10 most common referrals. They've been doing CT perfusion now for years, and they love it. Not one has stopped. We've got ER docs calling up and say, hey, there's 50 mLs of mismatch. You got to take this patient, right? And they found that it does decrease their liability for making a mistake, and it speeds things up, right? The ER is busy. They want a very quick in and out. And using the AI software, they can figure out what's wrong with the patient fast. They can get them to the right place fast.
Yeah, because I mean, I'll tell you right now, I read for several sites. Some of them have perfusion, and some of these hospitals are really rural and they are just doing non-con, and they have like limited availability on the MRI. And, when a patient's coming in with like stroke-like symptoms, I mean, some of the times they're very subtle or they're very small little infarcts, and all you can really say on these patients is sometimes when they have bad vascular disease and things. I'm just saying, like, no hemorrhage, no mass effect. If you're still concerned about it, you need to get an MRI. I mean, you think about how long that takes to get from one thing to the other. It takes a long time. I mean, most of the time you'll be able to see these like acute, large territory things, but like we were talking about, sometimes they start off small, the non-con is negative, and then by the time the MR happens, it's expanded significantly. If you had perfusion or RapidAI or some kind of AI app that's triaging the non-con, that patient could get treated a lot quicker,
It is a huge advantage of CT perfusion. Have several patients a year. They come in and they can't talk. They're not talking. They don't seem to understand. Rest of the neuroexam is normal. People are assuming it's a stroke. They're ready to blast in a thrombolytic. The perfusion comes back normal. It's not compatible with a stroke. It's a migraine or a seizure or functional illness. It's something else. So really, really helpful. Patients with vertigo, super common ER diagnosis. Somebody comes in with vertigo, and it's always a struggle. Is this central vertigo? Is it peripheral, right? most of it's peripheral, right? These are benign positional vertigo. You're going to send them home with antivert, but a small percentage of those patients come back in a couple of days with a big swollen cerebellum compressing the fourth ventricle, and it's a disaster. And you sent them home saying they had benign vertigo. So just as you said, it's hard to get an MR from the ER, but doing a CTP to see the blood flow to the cerebellum is normal. And we know this is not a cerebellar infarct masquerading as benign vertigo.
Yeah, absolutely. One of the things that a lot of, I think, at least when I read about the initial softwares, and I wanted to talk about how you guys have overcome this problem, is heterogeneity in the data and training an algorithm on a limited data set, like you were mentioning. It needs to be trained on multiple scanner types because, Philips is different than GE and the images are going to be different. Patient populations are going to be different from, Palo Alto to, the East Coast. So how did you guys overcome those issues in heterogeneity and things?
Yeah, we've had very nice customers early on who are happy to tell us when we were failing. And that's greatly appreciated. When a new module comes out, it's really important to get it out into the wild and see, because you're going to see different things than in the testing that you did. So you want to have good communication with those customers. You want to partner with them to look at the data and let you know when something's not working right. So we're getting a skull base artifact that's causing a false positive. And if we see that several times, then we know we need to train, not to have that skull base artifact cause a false positive anymore. So part of it is trial and error. Part of it is trying to be on top of new sequences. We had an experience with our Aspect software where the GE was trying some new thick overlapping slices to try to get, better resolution. But thick overlapping slices, when you tilt correct them to do an aspect score, they give false positives. So we got the word coming out, that we're getting crazy aspect scores. They said, so send us the data. And they sent the data and we said, well, let's just run this through with thin slices. It takes care of the problem. So a lot of it, again, is that you have to have some partnership with the customer, and the customer needs to realize that it's a little bit of a team effort to try to make sure that this software is working optimally at your site. And what we've now seen recently is some comparison studies where, you do a big 1,600 patient study and you see one software is picking up the LVOs very well and another software isn't. And people don't realize that just because you have an FDA clearance, that doesn't mean your performance in the real world is going to match that. And it doesn't mean that anything that's FDA cleared is equally accurate. So you really need to look at your institution. How is it performing in my institution with my scanners and my protocols, and work with the company to say, do my protocols match? CT perfusion was fairly new when we started to do this, and we found a lot of protocols that didn't make sense, right? They're not giving enough radiation to be able to see the lesion. So you shouldn't give any radiation if you're not going to give enough to see it. Or that the bolus was, not being timed right? They're starting to scan before the bolus arrives, or they're starting to scan 15 seconds after the bolus, right? So you have to be sure that the protocols are appropriate to get optimal performance of your AI.
And this feedback that you're getting is primarily from radiologists who are using the software.
Yeah, it's often from radiologists, yeah. And the other thing that we'll see is that people don't understand how to read a CT perfusion. That they think it's screwed up, but they don't realize that it's showing you the hemodynamics at the moment of the scan. If somebody had low cerebral blood flow yesterday and it killed some brain tissue, and now it's reperfused, that CT perfusion is going to look normal. And yeah, the patient has a stroke, but you're going to pick up the stroke with your low Hounsfield units or your MR. So realizing what CT perfusion does and doesn't do, because none of us, when we were in school, had a course on how to read a CT perfusion. So a lot of what I do is give talks on this is how it works, and this is expected. This is what you would expect to see, because the lesions are going to evolve depending on what stage of reperfusion you're in.
How do you combat over-reliance on AI in the future? We were looking at an article, young radiologists who use AI are more likely to rely on the incorrect result, whereas experienced radiologists can kind of parse it out. So, going through training, if you're getting all these already pre-prescribed outputs and you're almost saying yes, like how do we, I guess, get rid of that bias for the future radiologists?
Yeah, I mean, I see images every day for many different hospitals. And the first thing that goes through my mind is the AI right? Is it correct? Right. And in our conferences, we're saying, is it right? So you start with a little bit of skepticism. We know the vast majority of time it's right, which is great, but it's going to make mistakes and it can make some important mistakes. So from an FDA point of view, from a clinician point of view, you do not take it at face value. You always look at it with a skeptical eye and say, does this make sense, right? Is there truly an occlusion? And the software that's set up well, you can press a button and you're in the source images, right? So it's telling me there's a basilar occlusion. I want to see it. I want to see it on my source images. I push a button, or I've got a nice 3D reconstruction that you push and say, yeah, it's there. Or if it's not, then you try to say, what fooled the software? So it's a little bit of a game. It's like, oh, yeah, I can see why the software thought that, but that's an artifact. So you got to train people, young or old, that this is a teamwork. This is a partnership between you and the AI. And if it's done well, it's going to, be of great benefit.
How do you see the next, I would say, let's say 10 years going for AI, not just in radiology, but in clinical medicine as well, now that we're kind of expanding into EHR integration and all these kind of things? Like, where do you see us in 10 years?
So EHR integration is complicated, but it's potentially incredibly valuable, right? So that if you're trying to do a study and you're looking for patients who have this in their past medical history and no AFib or yes AFib, and being able to pull all that in, combine it with the imaging, you can have a huge impact on research and also on clinical care, right? Because it can tell you, this patient has a contraindication to TPA, right? Or, there's a contraindication lurking in the medical record. So, particularly in something where it's an emergency and you're trying to make a decision right away, you can flash and say, hey, this patient has an AVM, right? We're worried about this, or there's some type of tumor that's going to be a contraindication. So I think it has tremendous applicability for accelerating clinical research, finding the right patient. It's really hard for coordinators to know who the patient is that fits their study because they wait for one of us to tell them. They wait for the MD, and the MD is very busy. They don't always think, oh, this perfect patient for the study. So there's big advantages is there. But medicine is very complicated, and this is why, this is not putting physicians out of a job. You look at, neurology, neuroradiology. I don't foresee the AI being so good that it can have the clinical judgment that the physicians have. So I think it's going to make things better, more efficient for us, but we need to be there. I mean, for a routine case, it may be fine, but there's plenty of cases that aren't routine. You got to catch it's the unusual cause of stroke, or it's some unusual disease, like you said, that the obvious is not there. It's something. It's a zebra, and the AI is not there yet. The AI is doing things for very specified disease processes, but it is not covering the gamut, and that hopefully we're trained to cover the gamut.
Yeah, absolutely. I think that's something that a lot of medical students need to hear too, whoever's listening out there, because I know I get a lot of skepticism and a lot of doom and gloom about the field with all these new AI tools and how it's like the perfect scenario for AI and how it's going to be the first one to really make an impact on the job market. And I just think it's so multifactorial when you consider the current environment we're in and where we're doing in terms of radiologists and the number of scans and how that might explode in the future. And the fact that we're still charged with this verification process. We're still charged with knowing the basic physiology and the anatomy to verify that things look okay,
Yeah. And from a clinician point of view, the AI does not know your patient, right? The patients have different preferences. They, just looking at the patient tells you a lot about the patient, talking to the patient, what's important to the patient. The AI doesn't know that. So the AI cannot make clinical decisions. You need to make the clinical decisions yourself. The AI is going to help you make the best decision, but you make the decision that fits for your patient.
So just kind of a question we ask all of our guests. What's something, I guess, along this whole journey that you've had from, Stanford researcher to, starting a startup, participating in all these trials. What's one experience that happened in life or in medicine that really just rewired the whole way you thought about about medicine and healthcare as a whole?
So it goes back to where we started. I was taught that stroke was a stopwatch disease, right? That all the early trials that I did in stroke were a specific time window, and that was what everybody thought, that the study was positive because the time window was really tight. Or, I had so many patients that I said, I'm sorry, would love to treat your mom, but she came in too late, right? So the real, eureka moment was being able to see that everybody's stroke is different, that no two strokes are identical, and that most strokes are evolving slowly. So that what this tells me is that it makes no sense for the cookie cutter stopwatch, how you design your trials. You need to take what we call precision medicine. Where is this patient at with their stroke? Is there still salvageable tissue? How fast is it growing? Which AI can tell us. I can know in a patient who's 3 hours away, is that stroke still going to be small when it comes to me, or is it going to be 3 times the size? So realizing that we don't treat patients the same, we need to figure out what's going on with that individual and tailor the therapy to meet that pathophysiology.
That's great. And I think it ties into maybe some of the future directions for AI too, where we're doing more very precise care, where maybe factoring in some genomic factors in based on the imaging, and we have AIs that can do that for us. And then also more preventative care and things like that. Do you see a future in that for some of these tools?
Absolutely. Absolutely. We would much rather prevent a stroke than treat one. And, there's a lot of risk factors that are very poorly managed. So people are putting in systems together to, help people realize that their blood pressure is not optimally maintained. And, rather than seeing a physician once every 6 months, giving them real-time feedback that something is out of whack, their glucose, their blood pressure, their cholesterol, so that there's a motivation and a knowledge to help people optimize their risk factors.
Absolutely. Dr. Albers, thank you so much. This has been excellent. It is so great to hear from someone who's been through so much and has seen every facet of the field. Thank you so much for coming.
Yeah, my pleasure. Thank you.
If you guys enjoyed this first episode, please subscribe, like, share the video, make sure people know about it. Next week, we'll be talking about how radiology is affecting the workforce and whether or not we think we can close the gap with the upcoming innovations in artificial intelligence. So stay tuned.